that we have at the minimum 10 years of data to be able to refer back to it for claims data, data. And so that is not part of our scope as part of the Health Edge program. So what we've done is we've asked Source Edge, who is a partner with us currently, that is migrating doing the conversion and migrating our data from our legacy system to the current system, to also do develop a database and a user interface so that we can have access to this old data. So it is different than the current work that Source Edge is doing, but they are going to build this for us. Next slide. The reason we're going to do it in this fashion is if we were to have included the additional 10 years of data within the HRP system, it would have required a lot more complexity. We would have to build out benefits for the entire 10 years, even though they may have been expired in the past, and it would add additional scope, cost, and complexity to the HRP implementation. So what we've done is, again, ask them to build a system outside of this system so that we can have a read-only view of our claims data and our utilization management data and our auth letters. We've also previously discussed with our current vendor for them to continue to host a comparison, but that leveraging that would have cost us additional 75% more than this alternative for building our own system that we will own and maintain and have for the lifetime of MetroPlus. Also, the original vendor, while they're sunsetting the Power Step system, and we would have had an opportunity to purchase that source code in order to have this, they did not have any availability of the system. So we couldn't even go with the system. So it ended up becoming a non-starter for us. Okay. So we're looking to execute an agreement for them to build a system for us over the next 18 months for $2.3 million, which includes a 17% contingency as part of that build.
So a question just on capacity and long-term storage costs. How much data will we, I mean, this is 10 years history. How long will we hold that 10 years, and will it be like replaced by newer data, or will we always kind of maintain it?
So we'll maintain that existing 10 years of data, but as HRP goes forward, and we've sunset, so there's no need to prune out the data, so to speak, and once we have it in-house. But once we have enough established data within HRP, we'll be able to decommission based on compliance's approval, decommission this legacy in about another 7 years.
That was, does anybody else have any other further questions?
I just want to add a couple of words that just saying. For regulatory requirements, we need to keep 10 years.
Is that a typo? 27? Or should be 20? January 31st, 27?
Yes. Yes.
Okay. You want to change?
Good catch.
There are no further questions, and ask for a motion to approve. Second.
With the changes.
Yeah.
All in favor? Aye. Okay, so the resolution is approved. I'll go to the next resolution, authorizing the submission of a resolution to the Board of Directors of New York Health and Hospital. Authorize the Executive Director of MetroPlusHealth to execute a contract with Road Insurance Solutions, a business process as a service solution for Medicare and exchange line of business from an amount not to exceed $30 million for a total 5-year contract.
So again, as part of the Health Edge implementation, we need there are 2 lines of business that is currently managed by SS&C. That is our Medicare lines of business and our QHP lines of business. So as a replacement to the existing functions of those of that outsourced function, as we move away from SS&C into our HRP ecosystem, we need to have another contract with a different vendor in order to facilitate that work for enrollment and billing, for claims processing, from premium billing, the connectivity, the benefit configuration, the coordination of benefits, and keeping up with all the regulatory and compliance changes and configuring it within the system. And due to the specific requirements for this, there were a limited number of vendors that were able to perform this function. So we did a negotiated acquisition, which included solicitation to 6 vendors in order for them to see what they can do for us. And Wipro was awarded the next page, please. Wipro was awarded the contract. And so Wipro will provide a service that allows MetroPlus to outsource key operational and technological processes for Medicare and exchange. They will provide member reconciliation and premium billing, enrollment processing, benefit setup and maintenance, claims processing, and any regulatory changes. Next. So the minimum criteria for this work was at least 3 years of existing Medicare clients, 4 stars and above in their domain. They must have New York experience. Additional preference was to have experience in the QHP lines of business and have experience in the New York State marketplace. We use the typical evaluation criteria of the quality and proposal of their approach and adherence to the SOW, the relevance and quality of experience, and their compliance with technical and regulatory requirements, their costs, and NWBE implementation. As I mentioned, we sent out a negotiated acquisition to 6 vendors. 3 responded, 3 met the minimum qualifications, and the final scoring was concluded on 5-8. Wipro was the selected vendor by the evaluation committee. They have over 100 health plan clients with BPaaS services specifically for Medicare lines of business, which includes enrollment and billing through their enrollment platform. Wipro has a strategic relationship with HealthEdge and has worked on several implementations in HRP, as well as guiding care platforms. The all Wipro platform and data are hosted onshore in the United States, and all in-scope BPaaS services will be delivered from US locations. They have a long-term partnership with CMS as well, and a direct contract as a submitter for eligibility and enrollment with CMS. Next. In summary, we are seeking a 5-year contract starting in 1/1/26 for a total of $30 million, which includes a 20% contingency. Wipro has submitted a 30% MWBE utilization plan, and they'll be using ITRS, a New York MWBE company, for implementation and configuration. Staffing.
So I'd like to start off by pointing out, I think that this contract's actually going to save us money over our current spend. You know, it's a fairly significant percentage as well. So while there is a significant contingency, the expenses are still considerably less, and really just being prudent that the contingency is there. With that, I'd open it up to questions for anybody else.
Maybe I missed this. What was the term and cost of the last contract? Was not there.
But the current spend is a little over 5.2
Yeah.
million.
Yeah, it's correct. From 5.2 right now to 5.4, then 5.8 if we were to go into 2026. The implementation cost is about 5.2, and then the projected cost over the next 4 years beyond that is approximately the first year, which includes a little bit more of the implementation, is 4.1, and then it drops down to 3.9 and 3.5 for the subsequent years.
I just think that's important for everyone to understand. Does anybody else have any other questions?
Yeah, so essentially, I'm sorry. So essentially about $2.3 million less per year in the outlying years.
We may want to say, you said it here that the current system is being decommissioned?
Yes.
You said it?
Oh, you said it in the earlier one.
Oh, I didn't say it. Okay.
This one will have to go to
H&H.
H&H.
Okay.
So,
Actual add that.
So with that being added to the package, open up for a motion to approve.
Motion.
Second. All in favor? Aye. Aye. The motion carries. With that, Lauren, I'll turn it over to you for new business to discuss the finance committee.
Great.
Good morning, everyone. So we will be reviewing the overview of our Q2 performance that is through June 30th of 2025. We're opening up with the rate updates. Essentially, for the essential plan, there was an increase of 1%. That 1% increase is tied to the MCO tax that was effective January 1st, 2025. The MCO tax, for reference point, is a tax on health insurers that allows the state to pull in additional federal dollars. We also, in the essential plan, saw a negative adjustment to acuity on an EP5 population. They're a new population, started in April of 2024, and they are for the 200 to 250 FPL. For Child Health Plus, essentially the same theme, the MCO tax driving the increase to this line of business. We also picked up additional April revisions for the MLTC and MAP programs. This is an increase of 2.6%. And as the state is stabilizing with their statewide fiscal intermediary plan, we are receiving adjustments reflective as early as April 1, 2025 to support the needs of the population receiving CDPAP FI services. Next slide. So for our P&L across our lines of business, our overall performance for Q2 is in good position. The margin of 4% with Medicare and QHP now contributing to stable results. We're seeing, inclusive with our value-based payment arrangements, a medical loss ratio of 91.6% and an admin loss ratio of 7.9, both consistent with expectations. We are seeing headwinds on the Medicaid and HARP lines of business where we're seeing weaker performance. Medicare was closing the quarter with a negative VBP overall. We've picked up the MCO tax. It's now fully in effect, and it is for 6 months valued at $126 million. So overall, stable results, but we do have strong headwinds in Medicaid and HARP that must continue to be monitored. The state premiums and rate setting process are not supporting the cohorts that we are covering through their medical expenses. Next slide. On the administrative side, so budget versus actuals, our total administrative expense for the first half of the year is $188.6 million. This is favorable to budget by $10.5 million or 5.3%. It is about a 50-50 break where we see the personnel costs were about 5.8 versus the non-personnel of 4.7 favorability. The savings reflect discipline within our organization as we were understanding how the new budget bills will be affecting the organization. We did take active stance to look at our overall budget and be more prudent where allowable for the future. And this is going to give us some extra space in the back end of the year. Next slide. So Q2 regulatory reporting to forecast. So revenue net of pass-throughs came in about 4% above forecast. And that is stronger than expected membership and utilization trends. Expenses were just under 1% higher than forecast. We are seeing inflationary pressures and acuity adjustments driving. And then the result of a 2% current year margin, which does increase to 4% when we pull through prior year adjustments, knowing that there are still external pressures that are coming in the future quarters. Our current position as of Q2 2025 remains stable and the picture is strong. Next slide. So our current year operating income, this gives you the perspective just year over year of where we are versus where we were. And again, our net income lives at the 4% margin as compared to last year. And the bucket of the orange that sits on top, that's the amount of prior period adjustments that are being being passed through the plan for different state initiatives, whether it's for UPL, for MCO tax, when they're making rate adjustments we didn't factor in at the time of close. That's what that box is representative. And you can see this year versus last year, it's just growing every quarter with the state actions coming down the line. Next slide. So there are some other things coming down the pipeline for 2025. So we do have an increase above our projected rate. That is for the base rate on Metro Plus Gold. The pharmacy rider has no, we were able to leave our grandfathered, no rate change, no action. And then for our new enrollees, we are being as competitive as, fiscally as we can. And we want our members to be able to access the drugs that they need. And we are able to reduce that by 8% for individuals and 4% for family. There are a few other changes that are coming down at the back end of the year. We're anticipating to see additional April 2024 actions where they're continuing to move the MCO tax, the fiscal intermediary carve out. There will be acuity changes. So 2024 is still a very much active year. And then for April 2025 rates, when will we see them? Maybe by the end of the calendar year. We were, again, they're pulling through different updates for the same things at each quarter stop. So we're seeing that single statewide fiscal intermediary there again. And then we'll pick up any enacted budget proposals. And there is a transition benefit of doula services into managed. So on our assets, our organization asset base represents about $2.6 billion. That's 4.5% increase over the prior year. In Q2, I'll note our net worth has reached $1.1 billion. That's an increase of $100 million compared to 2024, with about $600 million earmarked for reserves. Go to the next one. On our investment side, our total portfolio is about $1.4 billion with maturities laddered through 2029. Our yield to maturity across the portfolio is 3.9%, which is favorable compared to the current market of 3.79. So our portfolio remains in a ladder program, and you can see on the right side of that chart, we're starting to fill in those back 2 years. So taking advantage of the market rates while still available for the long run is our strategy under the T-bills. So I'm going to turn it now to Elisa, who her and her team have put together our bid products with the regulatory bodies to go over the QHP Medicare and others.
Hi, everyone. So I'm going to review the QHP 2026 rate request. MetroPlus requested 10.1% increase, and DFS's final decision came in at 4.4%. If you look at the chart on the right, it shows our competitors, and DFS brought everybody down a total of 47.4% from their original request to their final decisions. We're seeing this equally across the market. From a competitive standpoint, we believe our profitable metal levels, platinum and gold, have been positioned to attract membership and retain them, whereas our our bronze and silver member plans remain the third lowest cost, which puts us in a strategically good place for where we can maintain a profit. For the 2026 Medicare bid, we are increasing our Flex supplemental card offering from $475 to $500. We're going to offer the same items that members could purchase, utilities, they can pay their utility bills, they can purchase groceries, over-the-counter items, bathroom safety devices, and the personal emergency response system. For 2026, we're going to be able to add pet supplies and chiropractic services. Additional supplemental benefits for our MAP Ultra Care plan will be unlimited transportation. And an additional benefit for our Medicare Platinum plan is we are adding a $500 vision benefit. And our large group MetroPlus Gold Care rate filing, MetroPlus filed for 7.9% rate increase. We were adding additional benefits by lowering the cost sharing and adding a vision benefit. However, DFS came back with a rate decision of -4.7. They changed the way they look at the look back period, and they identified 2022 as an outlier year and removed it from the filing review. And they looked at 2023 and 2024, and that is how they came to their decision. But in good news, effective January 1st, 2026, for the first time, we're adding a new large group to this plan, and they're PAGNI, our partners at H&H, and they already have 3 plan options. We will be the 4th, and with a 0 plan premium. We're excited about what's to come.
Okay, back to membership. Membership trends have essentially been stable. We have been running about 690,000 lives back since last fall. So we are anticipating some changes forthcoming in 2026, and we do see a tightening of the new members and the recertification that is happening on the population, causing small reductions in our overall lives, but we are keeping up with our large group product and our other new members that are being brought in by sale. Market share continues to be a stable point for us. We are keeping an eye. You can see on the SNP line of business, you're really looking at the green box here all the way to the left. You can see that we are gaining market share in the HIV SNP product, which is good news. MLTC has seen slight growth. We haven't really seen any material change to Medicaid, and our HARP and CHIP lines of business are now focused point for us to understand the decline in market share in these 2 populations. They are at the top mark for CHIP, we were at 20.1%. And then also for HARP, we have been in the 17s, for a large part of the bars on the screen. Recertifications remain at state level. So New York State level is at 80.5%. MetroPlus each month going from September down. May and June still open. I wouldn't call those closed, but you can see from April and up we have been at least at the benchmark level. There are nuances within that number for different lines of business. Different lines report back differently and take different strategic efforts to make sure we're maintaining the strongest research value we can. I'm going to turn the risk adjustment section to Nick.
So I'll briefly go over risk adjustment by line of business. I'm starting with Medicare. We continue to have positive growth year over year in our risk scores in this line of business, driven in large part by our in-home assessments that AdvantMed conducts for us. We are this year have completed about 2,300 in-home assessments, and we're aiming for 2,500, so running ahead of schedule for that. We also have initiated our chart chase, where we pick up additional patient information through record review. That is also running ahead of schedule. One headwind in the Medicare line of business is there is a large national effort to audit the risk adjustment results of all Medicare health plans. In past years, past administrations, they focused on something like 30 to 60 plans per year. the new administration is very aggressively trying to audit every Medicare plan. So that's over 500 plans a year, huge increase in auditing. And not only are they auditing everyone, they're also going back several years. So we are currently under audit for 2018 dates of service. And it is very likely that we will very quickly and aggressively be subject to additional audits for additional years. So we are in the midst of that audit. Right now we have been able to validate about 70% of the conditions that we've been asked to validate. It is challenging because, going back to 2018, some providers are no longer practicing, some records have been lost. And coding standards have changed. So that is where we're at. But the good news is we did get a little bit of additional time from CMS to, complete this audit. So that is Medicare. Medicaid and HARP, there's not a lot of news here. We've previously discussed the rates that came out in April, a slight increase in Medicaid driven by TANF, and then a decrease in HARP, but we are still the leading risk score in our region. Next slide, please. QHP, we have had a strategy over the last several years to sort of right-size this population. Elisa spoke about that, focusing on that platinum population, focusing on that gold population, which we know has high risk scores. This year, that is really coming to fruition. We are showing our best risk adjustment result ever with a projected $13 million receivable for 2025. An essential plan, this year, this information is a little bit old at this point. We're expecting new risk scores, this month or next, but we did see a slight decrease in our risk scores that we received last year.
So, we'll pass this over to Raven on the final federal reconciliation bill. I think we now have some information from the state on how they're planning to affect the folks in coverage gaps for at least the foreseeable future. There are a lot of other tentacles that have to be tied up, but Raven?
Excuse me, I just had two questions on the
Yeah.
presentation. On the rate adjustments, the
QHP slide. No, up.
Back up. Yeah.
Yeah, right here.
Yeah, just an outlier. I wonder what caused that.
So last year Emblem put in for a 40 to 50% rate increase. So I think because last year was so big, this year they put in for a little one, and they probably with more experience looked, and the state came back and said, you need a cut this year.
The DFS also issued a press release when they put this chart out in the news, essentially toting themselves on the back for saving the QHP members, right? Massive amounts of money. I think it was almost like $500 million. So they did have their own agenda to force pressure down.
And just a second question on Medicare audits.
Yeah.
Are they focused in are they different in any way? Are they focused in different area? Just what are they looking? Do they have a different way of looking?
So unfortunately, they're not providing a lot of guidance. So that's one thing, is they're not providing a lot
Probably
of
don't have
guidance
much
in
to
terms of
provide.
what the methodology is, what exactly they're looking for, how they're working. So that's unfortunate. But what we do know is essentially, we receive a list of members and we have to validate using medical records all of the conditions that are risk adjustable for those members. CMS has stated, in a press release that they believe that, health plans are being over reimbursed in their risk adjustment dollars, and they have set a goal of recouping $400 million from health plans nationwide. So it's clearly a financial play on their part. This is something that, Dr. Oz said in his Senate confirmation hearing. He believes this is an issue, and he is very, very, very aggressively going after this in his new role as, head of CMS.
Thank you.
Well, and there were findings, right, for United around Medicare and coding issues. So that I think ignited it. And then the other one, the reason they're so focused on it, they looked at the risk adjustment that's done by Medicare Advantage versus CMS. And there is a huge gap there. So they're saying it's not because the plans are doing the right thing and reaching out to members and seeing members at home and reviewing more than straight Medicare. They're saying the plans are doing beyond what they should be doing. But essentially what's driving it is that huge gap. And they're saying it's unjustified that the straight Medicare will be significantly lower than Medicare Advantage. So that triggered all of the audits across the board.
Thank you, Tom.
Reagan?
So we've been talking about obviously HR1, the federal budget reconciliation bill. Forever, it feels like at this point, even though it's only been 3 months. But as Lauren said, on the right side of the screen where it says we still don't know how New York State will respond. Insofar as it relates to the impacts to the essential plan, that we do know. New York still has not issued any plans or information as it relates to the Medicaid changes that came out of HR1, or the longer impacts, things like work requirements, shorter recertification times, all of those components New York has not addressed, but New York has addressed the risk to EP. So if I actually go to the next slide. So at the first dot on the bottom, January 26th, reduced number of qualifying immigration statuses. The long story short is that oh no, sorry. There was a longer version of this, but I presented to the internally town hall. Apologies. New York State essentially could not, in the way that the essential plan is currently structured today, continue without the federal dollars associated with premium tax credits for all of the individuals of varying immigrant statuses that are currently enrolled in the essential plan. In 2023, they had received a waiver from the federal government to expand the essential plan. And that was the creation of EP5, along with some other small changes like pregnant people being able to stay in EP. New York had to make the difficult decision to request that the federal government rescind that waiver, revert the essential plan back to its standard basic health plan format, leaving about 450,000 people currently enrolled statewide in EP5, or EP 200 to 250, without EP coverage. Some of those people will be eligible to go back to QHPs. For example, for MetroPlus, we had about 3,000 people that moved from QHP to EP when EP 2 to 250 went live. But the bulk will either have to try to get coverage through insurers or be uninsured. And New York State is still trying to figure out what to do about that population and how to help assuage those coverage gaps. But they did make the decision on how to save EP. By choosing to get rid of the waiver, they are giving themselves access again to what's known as the EP Trust Fund, has roughly somewhere between $9 and $10 billion in it, which will allow them to run EP 1 through 4, even without the associated federal dollars for, they're hoping, at least another 3 years, which is obviously two difficult choices, but they did what they had to do. And so now we know that EP, as of now, will be continuing 1 through 4 without rate changes, without significant coverage changes. And we're in the midst of conversations about what to do with EP 200 to 250 population and how to help their coverage as we go forward.
I think that New York State has all intents to keep the EP program intact for as long as possible. I think that as the timeline starts to move, they're going to want to stretch that finite amount of money for as long as possible. And there could be changes to the line of business as that timeline progresses. So while 2026 is being planned as is, I think we will have further challenges in the out years.
And one of the,
Just gonna, so what's the next benchmark for us to work from the state to get any kind of.
that is so optimistic. So let me say two things. On the EP side, the process of actually reverting back takes about 9 to 10 months. So we're looking at July 1, 26 for the reversion. So we.
It started, but the process has started.
Yeah.
They submitted the requests.
Yeah, so the state is aiming for essentially EP5, EP2 to 250 to cease to exist July 1, 26. So the first 6 months will be continuing as is, and then the reduction in the available population. In terms of the next steps, there essentially is no timeline. New York has options when it comes to things like work requirements and recertification to request extensions of those timelines. We know that they do intend to do that. We also know that CMS has expressly stated that those extensions will be extremely hard to come by.
Yeah.
I think initially states thought that they would be relatively straightforward to come by, since basically all 50 states say they can't meet the budget timeline. But that has not been CMS's attitude. So the way things have been proceeding with New York State, we really don't expect to hear from them until they have made a firm decision and are already essentially proceeding with their protocols. So knowing that they're already underway and taking action on EP, we may see some action in the New York State budget. That has sort of not been how they have been proceeding. But otherwise, I would not expect until mid 2026 at the earliest to really hear anything from the state. And that's probably a little bit optimistic, but that's what I would anticipate.
Well, what the state is officially stating is that a huge portion of those 450,000 are people who are taking EP coverage, although they have employer coverage. So they chose, because it's free, they chose to switch, because we were all surprised by how quickly it ballooned, right? So, right, so the assumption is, where did those people come from? Well, they came from employment, dropped their employment insurance that probably was more than zero, and came into EP5, and they believe that once EP5 is eliminated, a huge portion will go back into the employer space. I think for us, we need to look for the silver lining here, which is hard to find. But one of the thoughts is which employers and which individuals will really struggle. And the thought is here, probably the non-for-profits will be really struggling, right? Once whoever is eligible will come back into coverage and will be costing significant amount of money. So how can MetroPlus position itself in that anticipation to support the non-for-profits? Because right, the other employers are not our sweet spot, but these type of employers could be our sweet spot. So as we see the transition, we need to be strategic there.
And there were just a couple of other rules that were not HR1. Yes, other things HR1 exists that we just wanted to bring the committee's attention to, as they could impact the plan as we go forward. The first was that a new separate rule from HR1 removed eligibility for in QHP for DACA recipients. And so that will also reduce the available QHP population, and depending, it's not a huge volume in New York State, but it is significant, yet another pool of immigrants being impacted. On the state side, as of September 1st, there are stricter minimum needs requirements for eligibility to be enrolled in the MLTC line of business and also to receive PCS and CDPAP services. An individual now has to have at least 3 activities of daily living with which they need ongoing assistance in order to qualify, or they could have a diagnosis of Alzheimer's or dementia. And this is the critical thing, is that this is not being
affecting any current population. Current enrollees are grandfathered in, but it will reduce the population available for new enrollment as it relates to these services as we go forward.
So Raven, sorry, it went into effect September 1st. We haven't seen, I'm looking at Bing, and we haven't seen anything yet, right? It's way too early.
Means that, but on June to August, that utilization is being stable. Or, and
Yeah, it will be interesting to see what it's gonna do to the membership.
And then this is already described in the A&E.
I'll open it up for comments, questions.
There are no further comments or questions, so make a movement for adjournment. Motion approved.
Great.
Adjourn.
We'll be back in December with our budget presentation for 2026.